Good morning, everybody. My name is Ana Paula Velez. I'm one of the infectious disease doctors for USF, and I decided to start a new series that is called Infectious Diseases for that is called, we're going to be discussing different topics for the infectious disease boards. And of course, if you are preparing yourself for internal medicine boards, I think you can still pick up some few things good from here. All right, so today we're going to be talking about aseptic meningitis and encephalitis for the boards. And it was interesting because I was going through Google and I saw this picture about USF, best doctors. So I decided to put it here because our goal should be not only to do well in the boards, but also to be good doctors, like just the picture show. So anyway, so we'll start by a definition. When you see a patient that has any kind of CNS compromise and you think that an infection may be going on, it is important to differentiate between meningitis and encephalitis if you can, because that will give you a clue as what will be the potential cause of these clinical symptoms. So let's say, for example, if you have a patient that has a meningitis, it's different from encephalitis in the sense that in the sense that meningitis, often these patients may have some problems with the mental status, as far as they may feel tired, but they are usually oriented unless they're already in septic shock, and they can give you some details as far as their history and all that. But if you have a patient with encephalitis, the brain is inflamed, the behavior is bizarre, so they may not be able to tell you a lot about what's going on with them. So that's the main clinical difference between aseptic meningitis, between encephalitis and meningitis. So the definition of aseptic meningitis include clinical and laboratory evidence of meningeal inflammation with negative routine bacterial cultures. And I just wanted to point out that sometimes patients may have meningitis and you don't always find the meningeal signs, and that doesn't necessarily exclude the diagnosis. So there are different causes, and aseptic meningitis also includes you may see an abnormal CSF, including abnormal white blood cells, elevated proteins, low glucose, but the gram stain and the culture can be negative. So some of the causes of aseptic meningitis include some bacteria like TB. Spirochetes include Lyme disease, leptospirosis, rickettsia, Ehrlichia, Bartonella, Nocardia, Brucella. Viruses include Enterovirus, HSV, polio, measles, mumps, rubella, influenza, rabies. This is, as far as aseptic meningitis viruses is big, particularly Enterovirus in the United States. Fungal, we have Candida, blastomyces, histoplasmosis, coccidioides, zygomyces. Protozoes and parasites, we have Naegleria, particularly in a patient that has been exposed to fresh water. Acanthamoeba, the same thing. Nastoma, we're going to be talking briefly about this later. And then, of course, Plasmodium and Trypanosoma, depending on where the patient goes or where the patient has traveled. And then, of course, non-infectious causes. We always have that. So we have post-infectious, Guillain-Barré, and BCV, parainfluenza, influenza. Some of this may be sequela from previous infections. Medications, KT3, anti-inflammatory sulfa, penicillin, azathioprine, and rheumatologic diseases, lupus, Behçet's, and other vasculitis. So now, encephalitis. The main symptoms include headache. Again, these patients may present with altered mental status changes and levels of consciousness, disorientations, behavior. Behavior is important here. And And these may be accompanied by hemiparesis, cranial nerve problems, and seizures. How somebody can get encephalitis from, let's say, for example, a viruses. You can get spread from a viremia or from a neuronal spread, and that's the case for rabies and occasionally for HSV. Remember this, in United States, encephalitis, particularly HSV, you have to rule it out. And also don't forget about rabies. Other causes include arboviral diseases caused by mosquito. There are mosquito-borne that causes encephalitis, such as West Nile viruses and St. Louis encephalitis. But particularly don't forget HSV in a patient with clinical symptoms compatible with encephalitis. Worldwide, rabies, measles, particularly in Africa, and Japanese encephalitis. Patients coming from the South Pacific, Thailand, Indonesia, etc. So now, if they put you a case scenario of a patient who is from United States with clinical scenario consistent with encephalitis, you know that you have to rule out HSV because it's a treatable cause. So just remember that in adults, HSV encephalitis, I'm not talking about HSV meningitis, HSV encephalitis, the most common cause is HSV1, and it could be from primary infection or reactivation. And remember, behavioral changes, you know, somebody, let's say a wife comes and tell you, oh, you know, my husband started reading the newspaper today like always, and he wanted to eat some ice cream and put it in the newspaper, and that's not normal. So that's a behavioral changes. Loss in memory, important too, especially if it's abrupt. And they may have some olfactory and gustatory hallucinations, and it could be because of the location of the temporal lobe. Meningeal signs are often absent, may be present if they also have meningoencephalitis. And the CSF is abnormal. Red blood cells are a clue, however, they are not always present. And the diagnosis, if you combine MRI, that's going to show you abnormal temporal lobe. And or CT, however, the CT may be normal early in the disease, and that's why we prefer MRI. And the CSF PCR for HSV is important to obtain. However, if you do it early, maybe it's still negative. So the teaching point here is that if you see somebody with a clinical picture, you have to treat the patient. And you may need to repeat tests down the line in the course of the diseases to prove that it's not HSV. Because if you don't treat this patient on time, then the consequences are pretty bad. Particularly if you don't start, ideally you want to start treatment before the loss of consciousness or within 24 hours of the clinical presentation when the viral replication is higher. So you hit the virus in the right time. Because if not, then this is the consequence. And you see here complete necrosis, how the MRI shows how it lights up the temporal lobe, and the consequences could be complete necrosis of the lobe. So we want to avoid that. Now, another important cause of encephalitis in United States and worldwide is rabies. And rabies can be transmitted by bite, animal bite, or infected transplant tissue. There are some cases reported of rabies acquired after corneal transplants, kidney transplants. So that's another way to get rabies. Also, aerosolized transmission due to, for example, if a lab worker is handling a particular specimen, then that could be one source of inhalation rabies. And if somebody goes to a cave full of bats, then you, of course, has to be like a cave with a lot of bats to have that. So it may be another way to get it. Again, until now, no transmission of rabies has been documented in healthcare workers or people who are taking care of patients with rabies at home. And what you need is standard contact precautions with gloves if you're handling secretions of these patients. In the United States, these are the more important animals: bats, raccoon, scoots, and foxes. Bats are important. The exposures and the incidence of rabies secondary to bats has increased from 2005. And what happens is that often patients may be in direct contact with bats, but they may not be aware of a bite or a minor scratch or anything like that. So it is important, if they give you a clinical scenario in somebody that is being in contact with a bat, pay attention to the behavior to the bat. I mean, it's not normal that you are walking around and the bat is following you. That's not normal. So pay attention to that. If a bat, for some reason, is found in a house, the question is, do they need to be treated? And the answer is, if the bat is in the room, the person who normally sleep on that room may have been unaware of the bat bite. So the person who slept on the room where the bat was found, then consider prophylaxis, post-exposure prophylaxis. And then raccoons, skunks, and foxes. These animals in the United States, if there is exposure to one of them, they need to be considered an important exposure, and the patient needs to be treated until proven otherwise, unless you are able to capture the animal and observe it, in which case you can kind of observe, but often it's hard. So these animals are important. Now, small rodents like mice, rats, they are not really that important in the United States. Cats and dogs in the United States, they're not really that significant. You just observe the animal if you really think that the behavior is abnormal, and then prophylaxis is indicated depending on the animal behavior. But most of the time in the United States, no. Now, in developing countries, dogs are still important, accounting for rabies in more than 90% of the cases. And again, the rabies are important depending on, the higher chances of you getting rabies depend on how deep the bite is, where the bite is located. So if the face and head represent the higher risk as opposed to hands, if the bite occur through a tissue, is less risky than in a naked skin, because the saliva can be trapped in the tissue. So that's important. And as far as the clinical manifestations, there are three main clinical manifestations. Encephalitic form is the one that is characterized by hydrophobia, aerophobia. These are pharyngeal spasms after the patient is offered water, or when the patient tries to breathe, and seizures and all that. Paralytic form is more like quadriparesis, similar to Guillain-Barré. And then non-classical or atypical rabies is neuropathies and things like that. The diagnosis: immediately, if you're suspecting a case, you should call the health department or the CDC, and you should collect saliva, try to obtain a neck biopsy, serum and CSF. Brain biopsy is rarely performed in a live patient in those days. So collect saliva. Neck biopsy is about 6 millimeters deep, that include hair follicle in the hairline. And the serum and CSF fluid, what do you need to send it for? For antibodies and PCR. Now, the antibodies are important because if the patient was recently exposed to rabies, the antibodies in the serum may be still negative. So you may need to obtain several samples for that. Now, if the patient was already vaccinated, the serum antibodies may be positive. However, serum antibodies and CSF, if they're positive, the diagnosis of rabies should be considered independent of the prior immunization status of the patient. So as far as prophylaxis, we have the pre-exposure prophylaxis is indicated on vets, lab workers, or patients who are going to international trips where rabies is high, or where they're going to be exposed to animals that may have rabies. And post-exposure prophylaxis, basically what we talk, depending on the animal, depending on the behavior of the animal, and how the exposure occur and all that. Again, provoke or unprovoked exposure, important. This is how the animal behaves. Vaccination status of the animal, and of course, again, animal behavior. I think one of our fellows was describing in Thailand that multiple squirrels were attacking victims in the road, and that's something that is not normal to see in an animal. Like, it will jump out to the road and follow somebody. So that's very suspicious. So animal behavior. You have to clean the wound, and then the immunization in somebody that has not previously immunized consists in 4 vaccines, day 0, 3, 7, and 14, never in the gluteal region, because it has been shown that the protection in the gluteal region and the level of antibodies is not the best. And rabies immune globulin in the area around the wound, and the rest that is in the syringe should be given intramuscularly. It may not be necessary in patients who have been previously vaccinated, and these patients that have been previously immunized may need only 2 boosters of vaccine. Okay, let's move to a case.
There is another site, I think it's CDC site, it says 5 vaccines, 0, 3, 7, 14, and 28.
The source that I found was this one here, and I'm not sure if an additional one, like a 5th one, is indicated, but this is what I found. So I'm not sure about the 5th one. Yeah. Oh, this is okay. So moving to a case, Dr. Sanbunwit went to TGH after a well-deserved vacation in Thailand 1 week ago. Just pay attention to the incubation period, okay? And she was brought to ER by Dr. Menezes. They went out, and Dr. Menezes noticed that Dr. Sanbunwit was wearing excessive makeup, and she was dressed in a very provocative way, and that's not normal for her. So Dr. Menezes, no. So Dr. Menezes thought probably she wants to find a boyfriend or something, so she didn't say anything. But she noticed that her memory was a little bit impaired. When she asked her about the details of her vacation, she wasn't very coherent. But then she thought maybe she was a little bit drunk, so she didn't wanted to find more details. However, 1 hour later, she complained of headache and became rapidly lethargic. And she brought this picture that Dr. Menezes showed her about her vacations. And that's Dr. Menezes here. So she was saying, Mom, this isn't a rice field. Mom, this is a lot of work. I better go back to TGH. And then the mom said, just be careful with the mosquitoes. So the fellow who was on call was very smart, said Dr. Patel, say, rice field, interesting. So she was called STAT, and she requested an STAT MRI and also an LP. The PCR was negative for HSV. She was listening to the lecture. She knew that HSV is important to be ruled out, but that came back negative. The CSF, however, had some plocytosis, low glucose, and mildly elevated protein. And this is what the MRI show. Anything abnormal here that you guys want to make a comment? Is this area normal here? So this is a yes, and so this is and the basal ganglia here. Any idea what this could be? Well, let's look. What's the most this is a West Nile encephalitis or rabies. She likely went to a cave with play with bats, but she didn't want to tell anybody because she is very introverted. She doesn't want to share her hobbies, and she was afraid of Dr. Sinot. Japanese encephalitis or HSV. So remember, she went to Thailand. Yes, Japan. Yeah, she was in Thailand and in a rice field right there, and she had encephalitis. So that's a clue. And so whenever you see somebody with encephalitis came from an endemic country, that we're gonna see what are the endemic countries behaving like that, then of course you gotta always rule out HSV and all that, but that's a clue. These are the areas where HSV encephalitis may be important. You see China here, you see Thailand. India, it depends. It depends if you go to the rural areas, and Singapore, Cambodia, and Indonesia.
Not really in Japan.
Well, the what? I'm sorry.
Is it in Japan or?
Yes, yes, but yeah, some of these areas it depends where you go. See, like if you look at a map, yellow fever, Colombia, everything is high, supposedly is high, but you have to ask the details because in my city I never saw a case, and so it's mainly in the jungle. So you have to ask specific details, but in general. And moving to, so this moves us to arbovirus as a cause of encephalitis, and these are some of them. And I'm not going to discuss each of them because pretty much we'll be here forever. But anyway, the most important things of each of them. Arbovirus, remember, are the ones that are transmitted by mosquito, and many of them are encephalitis kind of picture, and the symptoms are difficult to distinguish between them. But one thing that you want to keep in mind for the boards is the incubation period and the unique feature of them. Where the patient went. That can help you to distinguish among them. So Japanese encephalitis, and I should have included that one also on the previous case scenario. GI symptoms, maybe the unique feature, and rice fields again, incubation period, and most of them, if you have an incubation period beyond 2 weeks, it's not likely to be one of these arbovirus encephalitis. Most of them are the mosquito, and other animals affected may be birds or horses or rodents, depending on which one you're looking at. So California encephalitis, important features, seizures, and school-age children. So they'll give you school-age children that comes from the Midwest with seizures. This is one thing that you can keep in mind. West Nile encephalitis, flu-like illness plus palsy. Again, these two are important in West Nile, and I'm sorry for the row, he should be here. San Luis dysuria, and look at the locations. Eastern equina, Venezuelan encephalitis, and Western equine that I didn't include here. Patient from Central America and South America. In Venezuela, they often include in the case that the horses are sick and people are sick and they come from Venezuela. So think about it. And also sometimes even from Florida and Texas. So the part that is close to South America. And yellow fever. And I'm not going to discuss this one in detail because I'm having another talk about hemorrhagic fevers later. But encephalitis plus jaundice plus bleeding in a patient who comes from South America or Africa open your eyes. It could be a clue. And this is a nice picture that I found about West Nile encephalitis in 2007, with very high cases in Texas, California, Nebraska. So you look at the number of cases here that was reported West Nile encephalitis in 2007 from the CDC. And just to remember this, they may ask you, I don't think so, but they may, in case that they give you a case with a patient with encephalitis and they don't tell you specifically Venezuelan encephalitis, but they tell you Togaviridae, the virus pertains to this family. So something to keep in mind. These are the Flavivirus, Bunyavirus. Californian, is a group of viruses, and La Crosse is the main one that is included in this group. So just to keep in mind that these two are like the same. And polio, Coxsackie, and echovirus belong to Enterovirus and then Picornaviridae family. These are other clues that you can see on MRIs. HSV, don't forget temporal lobe, Lassa fever, choroid plexus, Japanese encephalitis, brainstem and basal ganglia, and rabies, thalamus, brainstem, and cerebellus. And moving to another case, 30-year-old male from Florida, previously healthy, complaints of headache, neck pain, fever, nausea, vomiting, and maculopapular rash in his trunk. The episode started 7 days ago. He was working in the yard during summertime, so summertime is important, and 7 days ago is important. The rash is important. He's a veterinarian. This could be important or not. We'll see. He has an indoor dog. He denies any traveling. He's married. He's monogamous, so no social behavior, no risky social behavior. His physical examination, he has a fever. He's alert and oriented. Is this a meningitis or encephalitis? Meningitis. Because and again the CSF was abnormal, but he's alert and oriented. His medications include ibuprofen for chronic back pain. Oh, and then we say this already. He has neck stiffness, and this we say already. And this is the rash, like a maculopapular rash. Again from Florida, 7 days incubation period. No high risk social behavior. No recent traveling. What do you guys think that is more likely to be the cause? Meningitis secondary to anti-inflammatories, acute retroviral syndrome, lymphocytic choriomeningitis, rickettsia meningitis, or enterovirus meningitis? Is it this which one? Well, the problem is that I'm not sure. I mean, it doesn't cause rash. It doesn't cause rash. Could this be acute retroviral syndrome? It could. However, we say that he doesn't use drugs, that he doesn't, that he is monogamous. Well, that's what he says. So, but in the boards, you have to believe what they what they tell you that the patient is doing, assuming that we are in the ideal world. And rickettsia, I mean, I'm not sure how common it is to see a rickettsia. It's a good thought, but remember he comes from Florida. And then could this be lymphocytic choriomeningitis? What's the main thing that they will describe to you? That the patient has a rat or mice or something. That, remember, lymphocytic choriomeningitis comes from a infected urine from a rodent. The patient is a veterinarian, but I mean he could, but but yes, yeah, that too. Yeah, if he had a recent organ transplant, they had been described. Enterovirus is the most common cause of aseptic meningitis. Meningitis, I'm not talking about encephalitis. Meningitis in United States, associated in summertime, Summertime may be accompanied with rash, and as opposed to bacterial meningitis, the patient may not look as sick. They may still be sick, but most may not be that very sick. Some of them, yes. But not always. Some of them, they may tell you that the family, you have to ask about the family if they have had any sick contacts. They may tell you that, oh, everybody's throwing up with nausea, vomiting, diarrhea, but they didn't. But they came with fever and rash, and meningeal signs may or may not be present. A headache may be present, photophobia, etc. Yes, and I should have included that one. They should have included that one, but it was going to be very easy, too easy. So again, the most common cause of aseptic meningitis in the United States, incubation period 2 to 7 days, spread person to person by enteric route, a history of a sick contact, the patient may not look very sick, summer or fall time, rash often present, and the diagnosis is CSF PCR for enterovirus, can be positive in up to 75% of the patients. Just remember the family of enterovirus: polio 1 to 3, echovirus, all this, Coxsackie A and B. And remember that Coxsackie also causes hand and mouth disease, pleurodenia or devil's grip, pleuritic pain with very severe, and may cause myocarditis too. HSV meningitis, not encephalitis, also can be seen, and in contrast to HSV encephalitis, which is most of the time due to HSV1, HSV meningitis in immunocompetent patients is generally caused by HSV2, and genital lesions may be present. So that will be a clue. A patient with meningitis type of picture, aseptic meningitis plus a genital lesions, thinking HSV2. Look at this, up to 85% of the patients. Okay, and moving to recurrent molar meningitis. Also HSV2, but as opposed to the initial or just a single episode, genital lesions may not be present. And some of these recurrent episodes of meningitis, that is called molar meningitis, they may be due to HSV1, or some of them may be idiopathic. Okay, moving to a case 3. A patient comes complaining of sore throat, worsening headache, myalgia, and fever during winter time. So there's a clue here. 22-year-old female, previously healthy, with progression of symptoms for the past 3 weeks despite of acetaminophen. She denies any mosquito exposure. She has a rash in the trunk and diarrhea that has been present for 2 days. She's a model. She has had unprotected sex. She denies any drugs. She drinks 4 to 5 margaritas per day. She recently traveled to Middle East for business, and she wasn't very specific. She said business. She has 1 dog, 3 cats, and one hamster, and she takes acetaminophen. Sometimes in the boards they may tell you that they went to Texas and then Middle East, and then you get confused with all these clue words, and all of them have rash and all of them have fever, but so you have to try to be picky, trying to get these words. And this is how she looks like. And by the way, this is my painting. Yeah, I paint, so this is a knife painting, and so this is her. She's not drinking margarita there, but that's how she likes to dress, and that's how she presented to you. Mojito, ron. She's drinking ron there. So the physical examination, she has fever. She looks mildly ill. She has a non-exudative tonsilopharyngeal congestion, and she has a soft palate ulcer. She has a rash. She has some adenopathies in the cervical and occipital area. She has meningeal signs. and that's a rash, a macular rash in the trunk. Her labs are consistent with aseptic meningitis. Cultures are negative. The MRI is normal. And which of the following tests will likely give you the diagnosis? PCR for HSV, PCR for enterovirus, HIV PCR, CSF for IgM for lymphocytic choriomeningitis. Yes. Why HIV? Because I gave you several clues there. Unprotected sex. The business that she went to do somewhere that she wasn't very specific, that didn't want to tell you. Sometimes patients, I just saw a patient the other day that when I asked him about his HIV test, he became very upset. When I asked him about previous incarceration, he was very upset. So, I mean, if they are upset, why are they upset? You know, why they behave like that? So something is weird. They are hiding something. So so she's unprotected sex. She drinks 4 to 5 margaritas a day. So it's a very risky behavior. You become drunk. You don't know what you're doing. So all these clues can point. And then you have a rash. You have lymphadenopathy, and you have non-exudative pharyngitis. And why HIV PCR and not ELISA or Western blot? Yeah, and you don't have enough time to have antibodies to be detected. So this is the diagnosis of acute retroviral syndrome, HIV PCR. The other one may be negative. So again, mono-like illness, rash may be present, pharyngitis or oral ulcer, and risk factors. And just briefly about meningitis secondary to parasites. Acanthamoeba negleria, fresh water exposure. Kids that go and swim in a fresh water come with meningitis type of picture. Think about these two parasites. Angiostrongyloides cantonensis or rat lungworm, South Pacific, eating raw or undercooked snails or crabs. Nastoma, patient from Thailand or Japan. The larva migrates to tissue and to the CNS. And just remember to differentiate between meningitis and encephalitis. But for rabies, important. Eosinophilic meningitis causes this: angiostrongyloides, Nastoma, Naegleria, and coccidioides. So they give you a CSF with eosinophils. You will be very happy, because if you remember this, you're probably going to get the diagnosis. Hopefully they don't list all of them. And remember, when you're seeing a patient with encephalitis or meningitis, traveling history, mosquito exposure, time of the year, sexual history, presence of absence of genital lesions, pets or contact with animals, incubation period, and other symptoms. And even, I didn't put here, but sick contact is important. For example, for enterovirus. And thank you. I'm sorry for the slide came like that, but that's the end. Any questions? Yes. Oh, yes. Yes.
If you're going to order HIV PCR, I would suggest you specify DNA PCR, because if you don't, they'll give you an RNA PCR, which still may not be positive.
Okay, so the comment that Dr. Tony say that if you're suspecting an acute retroviral syndrome and you're going to order HIV PCR, make sure that you say DNA HIV PCR.
The second was with the confusion about with rabies vaccine, whether that there was a fourth dose. It's
Fifth.
21 or 28.
Oh, 20. Oh, okay. So it's 20. Oh, okay. Yeah.
Not 5 days.
So the fellow brought an important question, and was if after the patient has been exposed to vaccine, if you need 4 or 5 vaccines, and then the point that Dr. Tony say that is 4, but the 4 instead of could be either at day number 21 or 28 day, either one, but it's 4. Any other questions or comments? Okay, thank you so much.